Hello, I'm Giza Lopez. I'm the Executive Director of the New York State Youth Justice Institute. It is my absolute pleasure to welcome you today to our Lunch and Learn session that features Dr. Stephen Phillippi. I'm so eager to hear from him. Typically, the YJI team webcasts from Albany, New York. Today, however, much like our audience, we're scattered throughout the entire state and beyond. I extend my welcome to you from Seneca Falls in New York. As you may know, this town hosted the first women's rights convention in the United States back in 1848. Just a few minutes from here in Auburn, Harriet Tubman's house still stands and is now home to a museum. I bring this up as they struck me as tangible reminders that despite the long history of the fight for race and gender equity, we still have a long way to go. At the YJI, these are, of course, front and center to all of our actions. I will turn this over to Brian Rainey, who will properly introduce Dr. Phillippi and briefly cover some housekeeping items. Thanks again for being here today. Welcome, and Brian, take it away.
Hi, everyone, and welcome to the YJI's Lunch and Learn webinar series. As Dr. Lopez said, my name is Brian Rainey, and I'm a graduate research assistant with the YJI. So if you've never joined us before, the goals of this webinar series are to, 1, act as a resource for cutting-edge research on juvenile justice issues, 2, to provide this information in an engaging and thought-provoking format, and 3, to bring together scholars and practitioners from various fields to explore these issues. I have one housekeeping item in the calendar invitation email that was sent out last week and in the invite this morning. We included a link to a web page showing how to access all of the features used today. So please reference this resource if you're having issues with these features. We highly encourage you to submit your questions as they come up as well. There will be points throughout the webinar today that are designated for answering audience questions, and we'll have a Q&A portion at the end. We ask that you put all of your questions for Dr. Phillippi into the Q&A section, and comments can be submitted through the chat. And now that that minor housekeeping item is done, I think that we're ready to hear from an expert in the topics of behavioral health and evidence-based practices. Dr. Stephen Phillippi is the chair of the Behavioral and Community Health Sciences at LSU School of Public Health, He is also the director of the Institute for Public Health and Justice and founding director of the Center for Evidence to Practice, both working to bring evidence-based practices and supportive policies to states and local communities. He is a licensed clinical social worker and clinically certified forensic counselor. He has a 25-year history of developing, managing, evaluating, and providing direct services. Dr. Phillippi is the PI on several studies. He teaches, writes, consults, and participates in a number of professional and public service boards. So without further ado, Dr. Stephen Phillippi, everyone.
Thank you, Brian. And thank you to the Youth Justice Institute and Dr. Lopez and everybody else that has been involved in putting this together. Pleasure to be with you. I wasn't sure I was going to be with you because just 2 days ago we were in hurricane preparation mode, thinking that we had 2 hurricanes coming right towards New Orleans. I'm glad I can be here, and it's relatively sunny outside. So thanks for having me. I'm going to walk through just what we did in Louisiana, more or less tell a story of what we as one state, one case example did to move forward evidence-based practices. It was done with a lot of help from a lot of people, which if I had to give the ending to the story up front, this was no singular effort, and anybody that's interested in taking this on needs to connect with a whole lot of systems, individuals, expert technical assistants, you name it, because this was a heavy lift, and it involved many, many people that I am sure I won't have time to even remember and recognize all of them throughout, but I'll try and do some of that. For those of y'all that have been around criminal justice for a while, you may know this one, especially if you prescribe to the or subscribe to the American Correctional Association journal. Back in the 1990s, we were actually the cover story on the American Correctional Association's journal, and it was the largest youth prison system per capita anywhere in the world, not just the United States, in the world. We had more kids incarcerated in Louisiana per capita than anybody else. The atrocities were significant. I actually came out of doing community work, where I started as a court officer, probation officer, working mostly with status offense youth and their families, to come to Louisiana State University for specifically to address a major lawsuit that had been filed against the prison systems for the youth facilities in Louisiana, where they were sued for the poor conditions of confinement, poor access to health care, you name it, and LSU took over all the health care. So I spent the first 5 years of my work with LSU actually in the juvenile correctional facilities, helping develop training modules, also healthcare, social work programs, substance abuse treatment programs, et cetera, et cetera. But that's the old story. I moved back into community-based programming, specifically what I'm going to cover today under, when we took on, we were one of the states that did Models for Change with the MacArthur Foundation. And we literally moved into wanting to take on evidence-based practices. So when we were talking this presentation about implementation science, so this is my poor attempt to put implementation science in a slide. The good news for all of you all that are watching this is I'm not going to walk through any of this, but I figured you'd at least, those of y'all that do this, you could certainly see the complexities and you know this world well. The one thing I will take away from this slide from you, or highlight from this slide, is simply the implementation science in behavioral health, to take something that we know works to the population that needs to receive it, takes a very long time. The people that invented, discovered multi-systemic therapy, functional family therapy, they've all retired now. And you can, you still look at how much reach still needs to be done in those programs 30 years later, and there's still so much more room to go. So this takes a long time. We don't do it fast, but that's part of the story of Louisiana that I do want to touch on. So like I said, we were part of the Models for Change program, which was a initiative of the MacArthur Foundation, where they came in and selected 5 states that they poured a lot of resources into. So a lot of people will certainly jump to one of the conclusions, which I'll just give you up front, which is this was funded, and this effort was funded. It was very specific, concentrated funding from the MacArthur Foundation to help us literally scale up evidence-based practices across multiple places in Louisiana. So the goal of that grant, that contract work with MacArthur Foundation, and we were doing this as part of also associated with national groups. The affiliation with Albany goes way back. So Policy Research Associates, at that time, National Center for Mental Health and Juvenile Justice, led by Joe Kokoza, at the time was part of our technical assistance, part of our mentor group and leadership that came and helped us do this. So it's good to have that connection always back in Albany as well. But we were seeking to make sure that this was outcome driven. A lot of times when we start making reforms happen, policies take impact, we start shaping changes, we forget to look at the end of it all and say, did we actually make an impact? So we wanted this to be outcome driven. It had to be stakeholder aware. And again, one of the things that I'll highlight really quickly before we get into strategic implementation is when we talked about stakeholders in Louisiana, I think one of the things that set us apart from other states that tried to do similar reforms is our stakeholder network was broad. We were one of the few groups that brought district attorneys to the table as one of the key gatekeepers for these kids and families coming into the system. We brought law enforcement on. We, of course, had judges involved, public defense. But a lot of people didn't look at that law enforcement side heavy enough as part of the necessary people to be at that table. We had legislators involved. We had lots of local leaders, providers, et cetera, but raised a whole lot of awareness with stakeholders about why evidence-based practices? Why is this even a big deal? Why should we even be talking about it, working towards it? So that was a focus. And then the last was strategic implementation. And again, what set us apart from other models is if you looked at models at that time, and this is going all the way back to 2006, there was basically two big standing models. You had one that was largely represented and pretty well documented at the time from Washington State, where the state came in and said, here's what we're going to implement. Here's the five evidence-based practices we're going to do. Pick one of them, or you don't work with any kids in the juvenile justice system kind of approach. And that's probably oversimplified and overstated, but it was a very top-down controlled scaling of evidence-based practices where the state selected and then the local jurisdictions, if they wanted to be part of that providing services for kids and families, they needed to select from those five. We then also looked at California, who had a community base, so literally a bottom-up, kind of a grassroots approach to building evidence-based practices, and it was the total opposite extreme where they were going into local communities. They were helping assess the needs, the gaps in those local communities, helping work with them to identify the evidence-based practice that might best fit, and then growing it from there. Both models had some success. They both had a lot of limitations. So part of the short version of this story is we combined both. We thought it was important for the state to have a big part of knowing what was being asked from local communities to figure out how much state support we could bring into this, and then also making sure local communities felt like they had some say in what practices they wanted in their community, and if the state was willing to support that. There was a lot of moving parts as when you start looking at system change, and I literally came from being a solo practitioner to doing community-based programs, working in that small world, to working in the big arena of state government policies, budgets, and every step of that way, you just increase the variables and all the moving parts. And one of the moving parts here was Louisiana was really good at the time in investing heavily in its correctional system, including that for kids. And you can literally see part of the effort was working at the state level of could we free up some of that money that was so heavily invested in facilities and bring it back to community care. And you can literally see the black part of this graph is the amount that was going to residential correctional facilities versus the money in 2011 that literally flipped, and most of the money then was coming back to communities. And that was part of the strategic implementation, was to make sure we were investing more on the front end and less on the back end. That also came with a big population reduction in correctional care that allowed for some of that to happen. So when you're implementing and trying to sustain evidence-based practices, there's a lot of moving parts, but I've narrowed it down to a few for this presentation for length of time, because I definitely want to get to y'all's questions, and those are the most important at this point. But somebody told me at one point, actually from the Technical Assistance Collaborative from South Carolina at one point, said basically politics aren't that difficult, just follow the money. So one of the things you got to find is who has the money and where is it? Because that funding, that budgeting, if you're going to do this massive initiative, you need part of it. And there's only so much money to go around, so you're taking from somebody, and you better know who those somebodies are. But you got to have, you have to have funding, you have to have budgeting. And part of the sell on evidence-based practices, of course, is they are supposed to be more cost benefit to them than doing business as usual. So making sure that funding is being spent wisely on programs that can produce outcomes. And we had a growing literature at that time that's saying we certainly had outcomes that were better than business as usual in the juvenile justice system. Marketing is an interesting thing. We watched literally some of the best evidence-based practices brought to areas, and those that were running them failed to market them because they believed you build it and they would come. But they were literally in a community sitting across from a judge that I'm on the phone with, and I'm talking about evidence-based practice, and the judge is saying, I would love to have those in my area. And I'm like, you do? And they said, who? And I'm like, multi-systemic therapy or functional family therapy or whichever one was down the street. They're literally right down the street from me. Never heard of them. Who is doing that? So you're literally setting yourself up for failure if you're not letting your own community know who are you? How do I even access this? Am I here? Do I have availability? So marketing becomes critical. Leadership and support, I cannot say enough about. This isn't about an individual. You have to build champions, and you have to figure out who the support for those champions. You have to start building the supports around those champions. One of the very strategic things we did was every time we identified a key group that needed to be part of our discussion, part of the scale up, we found a champion in that group. So for instance, for judges, I rarely spoke to judges. I certainly went to meetings, connected with judges. It's all part of making those connections. But we had a local judge, Judge Patricia Cook, that loved this idea. And she became our champion. She also happened to be one of the up-and-coming juvenile judges that was becoming the president of the Juvenile Judges Association. And she loved the idea. We didn't have to talk anymore. Judge Cook did all the talking for us. At the district attorney level, we looked at some of the leadership and who really bought into this idea of evidence-based practices. And the same thing, we brought in a DA. The DAs started making their own internal argument of why this was so important, public defense, et cetera, et cetera. And don't take for granted just because who sits on what side of the justice aisles there and everything, that they're all for it. Some of our biggest pushback was actually from the public defenders. And it made sense after you really thought through it. But, you know, a kid could go in and do their 30 days in detention and get out, and then somebody's saying, oh, but they would benefit so much from this evidence-based practice. And oh, by the way, it's going to be in your home, it's going to be intensive, and it's going to last for about 3 to 4 months. And we're just doing time figures at that point. And a kid is looking at his parents and like, I'll do my 30 days and get out. Why do I want somebody in our house and following us and being all in our stuff and in our business for that length of time? So trying to help the public defenders really understand the scope and the reach of evidence-based practice, and that there is a separation between treatment and supervised juvenile justice. This wasn't trying to catch kids to get them back into detention or catch kids doing wrong. This was to build skills and move them on because the outcomes were predictably much better than just spending 30 days in detention. Also then, last but not least, it's really important that if we're going to sustain these things, that we not only find funding that's sustainable, but we also link them to policies, and we start bringing groups, and we make sure policies in organizational levels at the state level also support evidence-based practices if that's where we're moving. So one of the first things that we did was we actually brought all the child serving agencies together, talked about evidence-based practice, and put out a position statement signed by every one of the child serving agencies that said, based on these outcomes that we're trying to achieve, we support evidence-based practices, and that's what we want to move to. And if somebody can't prove that they are an evidence-based practice, they should at least be evaluating their programs and giving data back to us so we can decide whether they are actually achieving the outcomes we hope for kids. And up until that time, the requirements were so loose that it was rare that anybody had to turn in those kind of accountable outcomes to say that they were really changing the lives of kids and families. So to the money issue, this was, we were doing this literally as the big recession hit back in 2008, 2008 was probably some of the lower years, 2010. And our state was scrambling. We were literally going from a state contracting model where all these providers would get paid out of a contract to work with juvenile justice involved kids, to a model where the state was trying to figure out, how do we fund these programs? And the answer was, we became part of Medicaid expansion. So with the Affordable Care Act, Medicaid was where the money was developing. So one of the things that we had to do is also then, in the midst of this, move from state contracting, where there was a lot more control and say already because of the stakeholder buildup, to working in a world of Medicaid that none of us had spent much time in. And that's a story in of itself, but I'll leave it there. But most of this left state contracting direct dollars, and is actually now, as of continuing to this day, mostly, and I'm just going to take liberties and say about 90 to 95% funded through Medicaid dollars now, and not state direct contracts. The other thing that's hard when we were doing evidence-based practices is the EBPs. They market themselves well. Part of the national portfolio, you can go to the list, Crime Stoppers, and list, and everybody wants to tout whose list they're on and how and where. But one size doesn't fit all. And one of the things that we run into over and over again is somebody goes to a conference, here's this great idea about this evidence-based practice, and they want to build it in their neighborhood. So trying to really help and provide technical assistance to make sure that you've got the right program for the needs, the gaps in your local area became very, very important. So we actually created a lot of matrices that we would walk into local communities with and really assess who's doing what with whom, where are the gaps, and then what evidence-based practice really fits that area. Do you have a high needs, high risk population? Do you have a medium risk, medium need population? Because it all makes a difference. And then you all, I'm certain, know the story for the low risk, low need. Do as little as possible. And that was part of what we also had to explain to communities. Get those kids out of the system. Low risk, low need, they don't need to be in the system. Let them do their community service work or whatever that accountability piece is, and get them as far away from the system as possible, because it has been shown over and over again that those kids do not fare well once they start touching the system. So we implemented selected EBPs that match the risk needs of the local area. And we had to decrease barriers. There's barriers to all of these, and the barriers sometimes are system-wide, and more often than not, they're also very locally driven. So what's the workforce like in your local area? Do you even have providers? You like this evidence-based practice, and I'll pick on multisystemic therapy for a second. We're in rural Louisiana. They really like multisystemic therapy, but I couldn't put five providers together to save my life in this rural area. So I've got one or two. What do we do? Do we find a different practice, or do we work within the confines of the developer and say, how does this work? One of the success stories, actually, of functional family therapy was in a rural environment of Louisiana, where there was 150 miles in the jurisdiction from one end to the other. They allowed us to piece together providers that were in different parts of that 150-mile stretch, and they would meet via, back then they didn't have Zoom. Zoom is a COVID new discovery, right? But they would meet by phone, and they became a provider team, but they did it more virtually than what had been previously required by the developer of the evidence-based practice. Staffing, training, administration, for time's sake, I'm going to keep this short. Very, very complex areas. These are never one-for-one exchanges. You can't go into an organization and just say, hey, if you just give us your providers and we can retrain them in an evidence-based practice, everything's going to be okay. That case manager, that treatment provider may be seeing 60, 80 people in their caseload, and then you're going to bring in an evidence-based practice that says, oh no, we capped that at 12. Suddenly you have all sorts of problems with how are we going to see all of our kids? How are we going to get them to fit in these evidence-based practices? So you have to have staffing models that appropriately address the needs and the numbers in the local area. Training, even when we come in and we offer, and I'm very sensitive to this fact because I've done this for several years now, but when we come in and offer our free training, training is never free. Somebody's paying for that provider's time to sit there. So some of these practices take, you're out of being able to bill any money for your agency, sometimes for 2 weeks while you're in training, while you're seeing your first cases and things like that, and still learning. Sometimes you're not allowed to bill. So there's a cost to training that needs to be scrutinized very well and just really strategically planned for. And then you need administration behind it. Having a handful of providers that really like an evidence-based practice will never replace having a supervisor or administrator that also backs that practice. That's what sustains it. That's what keeps it going. Making the evidence-based practices part of the policy and procedure. We've done a lot of work with that, especially around our juvenile drug courts, that the policies and procedures that drive our juvenile drug courts also contain very specific policies and procedures about the evidence-based practices and how they fit and who they fit for in the juvenile drug court. And then data and info sharing. And I know I'm saying this like this happens overnight. These are years in the making, sometimes months, just to get an information sharing agreement between an organization and the probation office so that people know who's coming, what are the outcomes, or is this still a good piece? Quality assurance, certainly licensing requirements. I think one of the things that like Washington State did very wisely, most of the evidence-based practices they selected up front had an outside developer that ensured fidelity and ensured that the license requirements were being met. As we've grown in the state of Louisiana and we've grown the array of evidence-based practices, that gets real messy. A lot of the evidence-based practices we have continued to do don't require that outside fidelity check. So how do you build that and build those checks within your own system, your own state, your own local area? Looking at outcomes, and then the infamous issue of staff turnover. Evidence-based practices are notorious for burning out young, zealous, excited new providers. They come in and, when they're working with 24/7 access, because that's what this model requires, it's hard. And there's a lot of staff that don't make it. So one of the things that we watch and is a continuing issue with evidence-based practices is there's a high attrition rate. So part of the plan has to be, how do you deal with that turnover? And is there a better way to address the attrition? So the end of the story, just to get to the point so I can hush and get to Q&A, is I said at the beginning, this was data-driven. So did it work? My favorite two slides, just to do show and tell, is 2006. This is what the state of Louisiana looked like. We had 4 multi-systemic therapy teams. We had absolutely no functional family therapy teams. With our work, and again, that top-down and bottom-up approach, we literally moved in 2006 to 2014 to look like this. 40 MST teams, 15 FFT teams, and again, that went from that original 4. So that is a massive amount of growth in a short period of time, especially for those of y'all that know implementation science. This stuff doesn't move this fast in most states. We were also recognized nationally. This was the work of Peter Greenwood, who would track a lot of the evidence-based practices from a criminal justice perspective. And we got a lot of attention for this because when he published this, prior to this publication in 2012, Louisiana wasn't even on this map. So we literally had gone from 2 years prior, when he looked at it in 2010, not being on a map, to suddenly in 2012 being the second rated for the most per capita functional family therapy, multi-systemic therapy in a state, and then it continued to increase in 2014. So we were showing definite increase. Now, you're in criminal justice, so that's great. So you've got programming for kids, fantastic. Did it make any difference? According to the impact, yes. So Louisiana is consistently above the national average for its arrest rates. And one of the things that we found is we implemented evidence-based practices. We continue to track those, and you can see where there was no impact on public safety. Arrests didn't get worse; they actually went down. We continued to keep numbers down in the incarcerated population of Louisiana's juvenile facilities. So arrests are down. We're not utilizing detention at high numbers. Our numbers continue to stay very low, going from a number of, I started with Tallulah in that first slide, where we had almost 1,600 kids incarcerated around Louisiana, to the numbers today are about 350 on any given day. And they've stayed stable. So relying on these evidence-based practices, community-based programming, an alternative to incarceration, detention, things like that, we've kept the arrest rates low and also the incarceration rates. So just a couple of things to highlight, these kind of just takeaway message. You have to have champions, and definitely don't be the only champion in your state. Have your champions that love your evidence-based practices, but also find those champions in the different professional groups that can be your voice with you, including legislative voice, judges, DAs, public defenders. So be inclusive as possible. I do think we had a great deal of success in Louisiana because we brought the DAs to the table early on, and the DAs in Louisiana are very powerful in terms of as a political group, and they were part of the ones singing with us saying we should do this. You have to figure out where the money is. There's only so much of it, so figuring out where it is and what can be a reline, that's a big effort, and it takes a long part of this planning and discussion with groups to figure out how to realign those, the dollars that are available and the people available. There's only so much in the workforce too. One size does not fit all, and that's probably my biggest cautionary tale to anybody that takes on an evidence-based practice. Just because you heard about it at a conference, just because your neighboring county has it, doesn't mean it's the best practice for your local area until you dig into your own needs, your own risk, your own gaps in services. Definitely ask for help. We wouldn't have gotten here without a lot of people. Policy Research Associates being one, the MacArthur Foundation being another. I know there's many other groups, Casey Foundation, and others have also joined in pushing evidence. Yeah, you go out and connect with people. But the tail end of that story is grow your own local experts. So part of the sustainability plan is making sure that when you bring that outside technical assistance, you have somebody inside your state that can also take it on and become that person for your state. So you're not constantly relying on outside folks to support. One-time money is just that. Most evidence-based practices by practice in terms of translational research, somebody gets a grant, somebody gets a great contract, they say we're going to do evidence-based practices, and 3 years later that money runs out, and so does the practice. When we set this out, we had a lot of support from the MacArthur Foundation, but it was very clearly set in motion with the idea that MacArthur was only a time-limited resource. How were we going to make sure this was sustained over time? And we did just that by moving a lot of the funding into Medicaid. So where are we now? Just to conclude, we've actually ventured beyond juvenile justice, and we've now working with the state's Office of Behavioral Health to do this very scaling up for their youth practices. And it still includes multi-systemic therapy, functional family therapy, but we're also doing 0 to 6 programs. We're doing programs for parents. We're doing programs for teens, transitional age youth. So our array of evidence-based practices has increased a great deal. but the model and the concept's still the same, and we're still very much looking for the sustainability of this currently through Medicaid. So we part of Medicaid expansion, we were part of the increased access. We quickly, the Office of Behavioral Health, Louisiana Department of Health quickly noted that access to care that isn't quality care isn't really changing anything. So that's why they asked us to come in. So we've now been doing this for about 2-3 years, and we're doing the same concept to increase the quality of care that kids and families that are utilizing Medicaid have access to, including the juvenile justice system. And that seemed like a whole lot of words in a short period of time, but I'm gonna hush.
Thank you so much, Dr. Phillippi. I would like to have some time for audience questions, and I'll get to those momentarily, but I have a few questions myself. The first of which is a lot of resources and attention are placed on EBPs, as you noted, but are they really the end-all, be-all? And what I mean by that is, do they deliver outcomes that warrant all of the inputs and efforts?
So great question. So I'm going to speak heresy of somebody that believes so much in evidence-based practice. The short answer to your question is no, they're not the be-all, end-all. There are areas of our state that it will always be very difficult to have a, quote, evidence-based program or one of these big models. Could we have research-informed practice? Absolutely, and we actually support research-informed practice as well. The problem with it is a lot of times I run into a provider, a probation officer, or a provider that just really is good at what they're doing. Given the limits of cloning, there's only so much we can do, and I can't replicate that person. So from a state system standpoint, I need to find something that I can replicate, and that one person I can't, but I can if we can get down to the components of a research-driven practice or going to the evidence-based program. This is why we rely on them, because I know I can replicate it, and once it's replicated, because it's been done over and over and over again, we can predict that those outcomes that are associated with that model are going to be outcomes that that local area is going to benefit from as well. Also, you pay attention to the outcomes, right? Some are really great at addressing delinquency behavior. Others are really great at addressing substance using behavior. Others are really good at working with families and engaging kids. Others are really good at getting around the engagement of the kid because the kid's very hard-nosed and unwilling to engage and works with the system around that kid to change the behavior. So it all depends on fit, but overall the short answer is they're not the be-all, end-all, but if you're looking to replicate and build a system, you're going to have more consistency and more predictable outcomes based on evidence-based practices.
I was wondering if you could speak a bit about the cultural and racial sensitivity of EBPs as well, I guess more generally, and then perhaps about specific evidence-based practices that you know of.
Sure. So it's a great question. It's a very fair question. Actually, it was a question that when we started doing this was raised by ourselves and several of the leaders that were working nationally with the MacArthur Foundation on this, which was, are we really pushing forward something that's culturally competent? A lot of these evidence-based practices, functional family therapy, for example, originated in a very white Midwestern kind of atmosphere. But as they've been replicated, most of these programs have been replicated. Again, a key for evidence-based practice is over and over again. So we keep looking at these replications as they go into new communities, working with different populations, different race groups and things like that, and question, are we seeing similar results? And the answer in short is yes. So the results are similar. There has been some research that talks about the matching of the provider, race, gender matching to the race, gender of the individual that's receiving the service, that it gives a slight bump in the outcomes. But overall, it's nothing that's so significant that you would say For instance, state the obvious, a white middle-class male like myself couldn't work with an African-American youth in inner city New Orleans. If I followed the model, we would expect equal outcomes. However, if one of my counterparts in the New Orleans programs, an African-American male would do the same exact approach with an African-American male, the research would suggest that you might see a little bit more of a bump in the outcomes. But again, nothing of such significance that you can say evidence-based practices aren't effective across different cultures. There are evidence-based practices that are growing that are very cultural specific. And I'm not going to remember all of them, and I should have been more prepared for this one, but if you look at some of the lists and you put in specific target of populations of interest, things like that, and you'll find that there's anger management programs that have some pretty good promising or evidence-based to them that are specific for working with African-American males. There have been actually a good example if you're working with young girls that have experienced a great deal of trauma and are also co-occurring with substance use. There's a program called Seeking Safety that has a great connection from a girl, at least the approach to working with girls in the juvenile justice system. They've also worked with females in the adult population as well, but it's got good outcomes. But it's it's that match again to what are the issues, what are the needs, what are the risks, and do we have an evidence-based practice that best fits that population? And then there's adaptations and things like that people have done trying to make things fit a little bit better with cultural sensitivity as well.
Thank you. So now I think we'll shift to the audience questions. If you do have a question, I encourage you to put it into the Q&A section. But here we will move to the first question. Someone asked, can you say more about marketing strategies or educating people about available EBPs to a range of stakeholders, judges, families, schools, etc.? You briefly mentioned that you did find ways to be responsive to the natural hesitation or tensions of youth and families needing systems involvement to sometimes access these services.
Great question. So kind of a two-pronged approach answer. So one is the kind of three cornerstones of really quality care are access, but the access has to be timely, and then the timely access has to be to quality care. If those three components aren't there, things fall off quickly. So when we talk about marketing, one of the things that I speak to the providers about is when you go and you knock on Judge Smith's door and you say, Judge Smith, I've got a great program. The day Judge Smith calls for you and says, I want a kid in that program, they better have access available in a timely manner. And then they have to be able to deliver it in a quality manner. So definitely timely access, creating that relationship between you and your referral. So one of the things that I said is follow the money if you're trying to figure out where the whims are. The other thing that's extraordinarily powerful, and we really spoke to this a lot with the judges, with law enforcement, with the DAs, the public defenders, is how much power they have in their referral. They have access to this population that these providers want to provide treatment for. And so if you're not getting what you want from those providers, if you're not getting that access, you're not getting that quality, the power of the referral is huge, because that does equate to money for them at some point. In our world, it equates to I'm not being able to bill Medicaid for services. But really helping the local organizations and everything understand that they have lots of power in referral, but that in terms of that provider group, making sure when they market, they don't oversell themselves, that people know this is how many slots, this is how to access them. If you need more, this is what we'll do to develop. But being kind of that truth in advertising, truth in marketing. The other thing that I also warn both sides, for instance, the judges and the DA and the providers, is when you're starting out evidence-based practices, oh my God, don't oversell yourself. We know that there's a learning curve to evidence-based practices, and you're not going to get the outcomes as you're learning and you're tripping over yourself trying to figure out the model. You're not going to produce these nationally known outcomes right off the bat. It's going to take a while. So there's that also that honesty, and we're starting this. We believe 6 months from now, a year from now, we're going to have a solid part of our community relying on this service, but it's going to take some give and take and working together to make sure we get there. So don't cut off all our access to money and referrals just because we have some slip ups. Because evidence-based practice, there's not one out there that's 100% effective with any kid. So making sure that that truth in advertising as you connect is also out there. You may be good at 80% of the outcomes or 50% of the outcomes, but you're not going to get it right all the time.
So one attendee asks, what do you think about the pivot we've all had to do to virtual services as it relates to EBPs like MST and functional family therapy?
Wow, that's a timely question. I literally, so the Center for Evidence to Practice, we were concerned about this very issue. We just concluded a telehealth survey trying to figure out how many providers actually made the pivot and how many didn't. And again, this is just our Louisiana sample, but we were able to get a hold of about 300 providers, which was a fair sample of our provider network. And only 14% totally stopped services. And the biggest group that stopped services was actually, and I'm a big fan of nurse-family partnership, but as an evidence-based practice, but they aren't part of Louisiana's telehealth Medicaid waiver. And so literally they couldn't get paid. So talking about that power of the payment, everybody else that we have under the Medicaid waivers and the telehealth waivers that said go out and do it, some did it very quickly. Others struggled to try and find that fit. We have some of our parenting programs. The ones that I saw struggle the most were the ones that engaged very itty bitty kids, the 0 to 6. It's a little bit harder to do it over the telehealth versus, but they figured it out. So most of our providers successfully actually transitioned, including multisystemic therapy, functional family therapy, trauma-focused CBT, cognitive behavioral therapy did a tremendous job on the shift. But they all did it, and the continuity of care was there. There was probably about a good 2 weeks to 4 weeks hiccup, but we actually sustained most of our services and have continued even with social distancing to be able to provide the vast majority of the services. Now, what we did find was the biggest problem is when we went to the social distancing and the COVID is the referral network was totally dismantled. Court shut down, schools shut down. And what was happening is our evidence-based providers were back to the marketing question. I've lost my entire referral network. I'm worried we're going to have to close our doors. So one of the things that we've stepped up and worked with is we've worked with our 211 system, which is our connecting to community resources so people would know. We've got this map that's actually up there is interactive. So we've been providing teachers and schools and the 211 system. We're reaching out to food distribution sites. We're working with community churches to give them information that links them to this site that they can blow up their local area and see exactly who the evidence-based providers are and make that informed decision about who they want to refer to, and families can make informed decisions about who they want to see.
Is there any long-term tracking of the outcomes for youth who've participated in EBPs in Louisiana systems?
We have. We've done a couple of studies, and we're actually just on the forefront of a pretty significant longitudinal study in Medicaid. But we did take some of our, we call them parishes, but our local counties that were doing FFT, MST, things like that, And we did track one of the great researchers in this area, Paul Frick, and some of his PhD students when we were working early on. We worked and we watched probation as usual. We watched probation supplemented by evidence-based practice, probation supplemented by treatment as usual, and they track those outcomes over time. And I wish I could remember the name of the journal and the publication title, but the outcomes were much more favorable for those that came through associated with an evidence-based practice than just supervision as usual or treatment as usual. So the name, and it was specific, the name brand evidence-based practices were outperforming treatment as usual in that county. So we did take a look at that. Our newest effort is we're really focusing, since we have functional family therapy, multisystemic therapy, and functional family therapy, child welfare, we actually have for our, we're building this data set of indicator codes, and you get incentivized payments if you do FFT and MST in Louisiana. So people are incentivized to use the specific code, and we're able to actually track that through Medicaid data that we have access to. So we can look at overall cost, number of sessions, diagnoses associated with who's going into what types of treatment, and then who gets hospitalized. And we're trying to also work on joining those data sets with potentially looking at child welfare and JJ outcomes long-term, who ends up in those systems as well. But we are paying attention to it.
So another attendee was wondering, how do you gauge when there's been enough studies of a high enough caliber that something can be considered as an EBP? So where's the threshold? It seems as though it could be a challenge given the low research quality of many program evaluations.
So a great question, and it's actually a very novel question. I don't know if you realize it, but there's also problems on the other end of that, which is even when you have enough studies, how old are those studies is the most recent kind of novel aspect that a lot of people are asking. So, so the typical minimum standard for a lot of evidence-based practices is you have to have at least 3 independent, randomized control or quasi-experimental studies with favorable outcomes, and you have to have that control of methods and dosage, so you've got some fidelity to be able to measure that we're associated with those outcomes when you speak of evaluation quality and things like that. So how many times have those specific methods, that specific dosage been linked to these outcomes for this program? And again, at least 3 of those independent studies before you're even considered up there on that more evidence-based practice list. And it has to be replicated in different areas. It can't just be 3 studies from one agency. It has to be replicated in different areas, different agencies. So that's kind of the minimum gold standard. There is, like I said, some pushback now because even some of the evidence-based that came out of some of the big models is very old at this point. A lot of the stuff that came out that put multisystemic therapy and functional family therapy, nurse-family partnership, multidimensional treatment, foster care, things like that on the map are studies that were done 25, 30 years ago. So there's some question of have those studies been replicated recently, and can we compare them now to what the new studies of different practices are, and is there a discernible difference? Are they still the best quality and approach for that population?
Apologies, I had myself muted. Someone else was wondering what specific changes and initiatives were implemented statewide as part of this transformational process and based on EBP research. Were those just at the programmatic level, as in types of programs or therapies provided to youth?
Part of the transformation, we looked at alternatives to incarceration. So that was, I had the evidence-based practice niche of this whole big project. Somebody else had alternatives to formal processing, and we did a lot of crossover work, working together, trying to see what evidence-based screening, assessments, and programs could help with alternative, directing kids away from formal processing. And then we were also looking at disproportionate minority contact, all at the same time, those three big areas when we were doing our reform effort. So there was multiple things going on. It was a massive reform effort, and the timing was right. Timing is everything. At a lot of times, a lot of those efforts are now shifted more into the adult jail system and less so emphasis on the juvenile system. So it's actually nice to be in the behavioral health arena where all of these continue to be issues that have a lot of state focus, a lot of state attention. So some of that timing and who we were affiliated with and where we sat in terms of strategic implementation were very important. And I don't know if I caught the second part of the question with that answer, though.
One moment. It was, were those just at the programmatic level, or in other words, the types of programs that therapies provided to youth? Right.
So at the evidence-based practice, we worked with agencies, programs. Some of these agencies are massive, and they have offices across the state. So big institution, agency level. Most of the agencies were small local agencies. However, the funding, training aspects of all of this was happening at a larger level. So yes, programmatic, but also happening from a state policy, local policy support level, and also making sure the money that was found, whether it was through grants and contracts or whether it was coming through Medicaid, that work had to be done at more of a system state level.
Thank you. I think that's it for the audience questions. But Stephen, I'd like to thank you today on behalf of the YJI and everybody in attendance today for presenting this really important work and useful work on evidence-based practices in several areas that affect youth. But before we close, I do have a few announcements and items to put on everyone's radar. The next session of the Lunch and Learn series will be on September 21st, and we will be hosting Dr. Richard Rosenfeld of the University of Missouri St. Louis, and he'll be speaking about his recent work on COVID-19 and crime trends and patterns. I'm putting the link to register for that in the chat. We'll also be hosting Dr. Shad Maruna from Queen's University Belfast in October, and November's Lunch and Learn speaker will be Lisa Good of Urban Grief right here in Albany. So stay tuned for those announcements as well. The YJI also has a new podcast series called Let's Talk About Youth Justice. The inaugural episode features a conversation with Dr. Timothy McCuddy, who spoke with me about traditional bullying, cyberbullying, and issues related to both. And the link to access that podcast episode can be found on our website. And shortly after we finish, we will be sending a survey to all of you via email. If you have the time, please complete the survey, as it allows you to provide further feedback so that we can improve the series. The survey should take no longer than 5 minutes. I'm also putting the link to that survey here in the chat as well if you'd like to do it right now. And finally, if you've not already done so, feel free to connect with us on Facebook, Instagram, Twitter, and LinkedIn. The links to those accounts can be found on our website as well. And just a reminder to everyone here today, the views expressed here are those of the presenter that do not necessarily reflect the views of the New York State Youth Justice Institute. And in closing, I'd like to thank you all for taking part in today's Lunch and Learn. We hope that you've gained something from this webinar and that you continue to think about evidence-based practices and what Dr. Phillippi has presented on today. We also look forward to seeing you at future YJI events and webinars. So thanks again, everybody, and have a great rest of your week.